this live case on the what we call PCR optimization. In other words, how to use the intracoronary imaging in order to get the best the result for the patient and the best clinical outcome, which is more important. So the patient is the following. It's a 57-year-old gentleman. You could see that he's a little bit overweight, but not a lot. But he has a lot of risk factors. All of the risk factors. He's diabetic, has dyslipidemia, has a strong history of family coronary artery disease. He has hypertension, and he has a previous history of revascularization in the 2011 PCI of two vessels, the RCA and the OM branch for unstable angina. And after 8 years, totally asymptomatic, this patient come back 1st of December with ischemic chest pain with an NST elevation, acute coronary syndrome. Biology investigation is quite normal, particularly the renal function is normal. When you look at the ECG, when the patient was admitted, it was a normal sinus rhythm, but he has biphasic T waves in anterior leads. And the most important was the result of transthoracic echocardiography, which showed us huge impaired left ventricular function with LVEF at 25%, with an akinetic inferior wall and a mild mitral regurgitation. This is the baseline angiographic, and you could see that in this view, the left main is at mild atheroma, but no critical disease. And there is this critical long lesion on the LAD with a large distal bed of this, with certainly some hypokinesia of anterior and apical wall. Critical lesion at the bifurcation of the diagonal, which is already diseased, and a lesion on the mid-proximal and mid-LAD, and the origin of the distal LAD at that point. In the other view, you could see that the left main is quite normal. Here is the lesion of the LAD and the diagonal. And there is, in addition, a third vessel disease with in-stent restenosis. You could see before the injection the shadow of the previous stent placed 8 years ago, with an in-stent restenosis on the distal part of the stent with a large OM branch in the distality. So the control angiography of the right coronary artery, which was treated by stent implantation of the mid segment of this dominant RCA, show a good patency of the stent, but some disease on the proximal segment of this dominant right coronary artery. In distality, the PDA has some disease and at the ostium, but it's a good patency, TIMI free flow, and the PL branch is normal. When we look at finally at the risk evaluation, the angiographic syntax score, so 21, and we look at the syntax score 2 with the 4 years evaluation of the 4-year mortality, it was calculated to 22% for PCI versus 73% for a bypass surgery. So normally indication for bypass surgery for this patient with 3-vessel coronary artery disease. But the patient strongly refused bypass surgery. And so today we have to deal with this really high-risk patient, 57-year-old, diabetic, with previous PCI on the right and OM, an acute coronary syndrome, low ejection fraction, 3-vessel disease, with a borderline 50% stenosis at the ostium of the right coronary artery, in-segment restenosis on the OM branch, which is significant, and this calcified long lesion of the LAD involving the origin of the diagonal branch. That's a bifurcation Medina 110 if you consider that the ostium of the diagonal branch is less than 50% narrowing angiographically. So now I think that we can move to the cath lab if the cath lab is ready. If not, if you have any comment concerning this particular case.
Okay. So Hussam and Shireen, welcome back. You guys hear us?
Yes, we do, Ibrahim.
Okay, Jean Fajadeh just presented the case, your case, and we did not discuss anything yet, waiting for you to tell us your strategy and carry on with the case, Hussam.
Sure. Good morning, all. Thanks again, Dr. Al-Rajdan and Dr. Fajadeh. So I think without any further ado, we're just going to go ahead and present from our strategy. Shireen?
Can I have the slide, please? So our strategy for this life case, can you go next? So basically, we have to use the utility of the FFR and physiological assessment of borderline lesions. And then we need to explore the utility of OCT in the lesion assessment and stent optimization. And finally, we'll demonstrate the provisional stent approach to LAD diagonal bifurcation lesion, Medina 110. So we used 6-7 French radial approach. We used 6 French GR4 guiding catheter for the RCA and to do the FFR of the RCA. And then the sheetless 7.5 French BB35 guide for the left system. We'll do OCT pre and post procedure, and then provisional stenting to the LAD using Xience stent platform. So initially, we started with the FFR of the RCA, which showed the baseline of the FFR. Can you show us the slide of the FFR? First of all, we'll show you the angio of the RCA. You can see here the cine of the RCA, the borderline in the proximal segment just before the stent, the previous stent. And the baseline FFR was, show us the slide of the FFR, it was 0.97. And after giving the intracoronary adenosine bolus, it went down to 0.82, which indicates non-hemodynamic significant lesion. And then we moved to do a right heart study and hemodynamic assessment, the baseline. And what we got that mean wedge of 10, RA pressure of mean of 5 millimeter mercury, saturation of the PA pressure was 66.5%, and cardiac index was 2.02. And the idea of doing the right heart study in this case, just because he had poor LV function, ejection fraction of 25, and we need to have continuous recording of his hemodynamics during the procedure. I will give it Hussam. He will tell you exactly what we did so far.
Okay. So thank you, Shireen. And so, I mean, the other thing I just want to add to what my colleague has just said, also looking at the RCA itself, the RCA is giving collaterals to the LAD. So we were actually thinking maybe this FFR could have been falsely positive, but this is all insignificant at this moment. So I think if you have no any further questions, we're going to go ahead and tell you what we've done for the LAD so far. Hello?
Yes, go ahead, Hussam. We're with you.
Okay. Sure.
Just carry on.
So we're done with the right heart study, and we're going to show you the angiogram of the left coronary system. As described by Dr. Fajadeh earlier, we talked about the bifurcation and the length and etc. I don't know if you can appreciate some calcium that you can see, but it's different than the calcium, for example, of the case that we did earlier this morning. So and the presentation is also different. So he presented with the ACS with the biphasic changes in the LAD. So in this, what we did, we actually wired the LAD. Next. It's just more, but I think what's critical just to see the angulation of the proximal LAD. Next, please. So we use first we wire the LAD with the BMW wire, and we wire the diagonal with another BMW wire. Then we try to use an OCT to image the LAD lesion, and as you can see, we were not able to advance the OCT catheter. So then we decided to use a smaller balloon, a 2020, next, and to make a path for this is a 2020 to make a path for the OCT to go. Next. As you see with this balloon dilatation, we have a nice expansion, and I don't know if you can appreciate the calcium is far away from the lumen. So it's probably deep calcium on angiographic assessment. Next. And then we tried again to take the OCT catheter, and again we were not able to advance it. And next. And you can see on the other view on the LAO card, you see how much angulation that we have. So we have an angulation there, and also we have calcium. Next. And that's the cine of that. And you can appreciate come back, please. On the lateral view, the S-shaped angulation in the lateral view. So here, next. And then even after that, we tried to take the OCT catheter, we couldn't. And our feeling was we couldn't advance the OCTs, not because of the calcification, it's more or less is due to the significant angulation. So then we tried to use the guide extension to help us support. So we have a 7.5 French guide. So we have a wire in the diagonal and a wire in the LAD. So I used a 6 French guide extension, which I could do. And then with that, I tried to advance the guide extension just to the proximal of the diagonal, because I have a wire in the diagonal. While doing that, I still couldn't, because I think I needed to advance the guide extension beyond the diagonal. So I had to remove the diagonal wire. Next. And so I just removed the diagonal wire. Then I put the balloon back into the LAD, and I inched in little by little. Next. I inched in little by little the 6 French guide extension just beyond the diagonal, so I can deliver the OCT. So I was very much adamant to assist the lesion with an OCT, and we've done all these steps so that we can advance the OCT catheter there. Next. So that shows you the fluoroscopic view how we could advance the OCT catheter beyond that bend. Next. And while we're doing all of this, we were just monitoring his hemodynamics with the PA diastolic pressure, as we mentioned earlier, because his ejection fraction is 20 to 25% and potentially non-viable inferior wall. So really, technically, and the circ has a disease as well. So technically, we're working on the last remaining vessel. So we needed to make sure that hemodynamics are okay throughout the procedure. And then we were able to do the OCT analysis of the segment that we are concerned about.
So can we see the OCT run, please?
Do you have any questions, or shall we proceed with the OCT, Ibrahim and John?
I mean, Hussam, you've done such a wonderful job. We would like you to continue, and when you're busy doing something, we'll do the questions. So carry on, please.
Got you.
Okay.
So Shireen is going to show you the OCT, and we're going to analyze the OCT image of the LAD. As we mentioned earlier, I'd like to use that acronym MLS. So we need to look at the morphology of the lesion. We need to look at the length of the lesion
and the size.
So that's before the intervention. And Dr. Shireen is going to go and explain that to you guys.
So in terms of morphology, it is a mixed black, a lot of fibrous tissue and calcium. Can you go from the beginning? Okay. And you can see here the calcium is more of deep calcium, not superficial. It's away from the intima. And you can see it is the arch of the calcium is less than 180. So between 90 and 180, so you have 1 point for the calcium volume score. Thickness is more than 0.5, so it's also 1 point. And the length is less than 5 millimeters, so 0 point. So a total of calcium volume index, it is 2 points, which means he needs just the traditional black modification with non-compliant balloon or cutting balloon if we need. But clearly it is deep. The distal reference area or segment measured around 3.0 millimeter, and the proximal reference area is around 4.0. It is just the 4.0 segment is just proximal to the diagonal, so just short segment of 4.0 measured 4.0 millimeter, but the whole segment of the disease is around 3.0. So the plan was, and the length of the lesion, the length is around 44. So morphology max black, calcium and fibrous, length is 44, and the sizing 3.0 distal and proximal 4.0. So the plan is to do non-compliant dilatation with a 3.0 25 non-compliant balloon, and then we'll proceed with the stenting and post-stent optimization with OCT.
I think one other thing which is really missing, and I wish we had it, is the OCT co-registration. If we really had the OCT co-registration, I would be very much more confident to put the balloon at the area that corresponds to the distal part of the area where we're going to stent. But unfortunately, at this moment, we don't have the OCT co-registration. But that would be a great tool to have while doing this.
Well, Hussam, while you're getting your balloon there, maybe we could discuss with the panelists some of the questions. Maybe the first striking feature is that Hussam was really adamant in having an OCT evaluation. Prior to going live, it was difficult, so he put a guide liner after balloon dilatation, multiple attempts. So it was a dedicated precision PCI. What do you guys think about that? Maybe I start with Abdurrahman Al-Mghairi.
Yes, I will do the same. Agree with Dr. Hussam for the evaluation of the lesion, and also prepare it well before the considering the stent, and also the to test whether we need also debulking device, either rotational or whatever the debulking.
The balloon is opened very nicely, so that's in agreement with what Shireen was talking about the OCT. Arif, you're an advocate of OCT, especially lately. Would you do the same?
We are doing this for the last 10 years lately.
Lately, more energetic, I mean.
Yeah, actually, certainly imaging again is the thing that will give us the insight of the lesion. The strategy will change upon what we see that we have learned now. We know what we are dealing with, and now he feels comfortable with going with non-compliant balloon. I wouldn't gone with this without imaging. I would have used rotablator or something else, debulking. But in this case now, after seeing the image, I feel more comfortable to go with the direct non-compliant balloon. So I think it's a good case to demonstrate this.
We have some, while the balloon is there was some slow flow, so maybe the balloon needs to go a little bit more further for dilatation. Hadi?
I'm really, Hussam and Shane, it's a beautiful illustration of dedication to doing imaging before these cases. Actually, what the image contributed to is actually safety even for the patient, because this is the only remaining vessel, and rotablating it, carrying with it, though a small hazard, but if it happens of distal embolization and no reflow would have been hazardous. So it helped us out just putting, a high pressure balloon, non-compliant balloon, so that we can do the procedure.
The guide came out. I'm just going to show you how I'm going to save this, hopefully, because everything came out. Let's see. Okay, now it's here. Let me take the guide liner if I could. So I have the guide liner in hand. You see that? Okay. Let's see. Go areocranial, please. So see the guide is in the aorta playing for me. Come towards me. Let me see the wire. All right. Let's test you in. Okay. Oh, you're off, Mag. So this is a non-compliant balloon. Show me the whole guide, please, yeah? So I advance the guide liner. I'm going to take the balloon there. Okay, sorry. Because I hate to lose my position at this moment. Go up here, just let 6 atmospheres only.
6.
Okay. Show me the guide, please. So while this is inflated, I'm going to hold the guide liner in position and the balloon. Show me the guide. The guide is playing with me there. See that?
It's hitting the.
Sorry, guys.
It's hitting
That's all right.
the inlet
Down.
of the
Down the
guideline.
balloon. Yeah. So everything came out. So I tried to save the position, but it's okay. Okay, let me just do that.
Nevertheless, Hussam, I think that's a great trick to get the guide in. So what Hussam
Yeah.
did is try to get the guide in. Now, it didn't work,
Maybe.
I think, because the guide was too far out and it was hitting the proximal
Give me the
edge
wire.
of the guide extension.
Yeah.
So we'll let you get the guide in again while we discuss some more issues, Hussam. Just go ahead.
Yep,
Dr.
sure.
Mohammed Subhi, I mean, would you do OCT in this case, or you just put a stent and forget about imaging?
I think it's let's go for the case from the first. It's 25% ejection fraction, akinetic inferior wall. We don't have viability, and they have FFR astonishing that the right coronary is 0.8. So for this case, I would do a Impella, and then I will start with the CX, and then improve it because the LED diagonal is very crucial. The only remaining vessels, so I have to protect myself. And they gave, as Hussam did, either OCT or IVUS to see the guide. If I don't have this, I think there's a calcification seen in the angiogram. So I have to plan. The problem is either do the angioscore cutting or non-compliant versus rotaplator. This is the issue of this. So I think the aim of OCT to see the amount of calcium, to see which technique is going to use it. So while Hussam is doing this, I think if it's difficult case, I think I should go out of the rotaplator because of this of avoiding no reflow in such case of 25% ejection fraction. I think the safest is do CX and then just ballooning and then go for angioscore and then stenting LED. And
So your answer, you wouldn't do imaging. That's the short of your answer. John, you have any comments so far on what's the case going with?
No, I think first of all, I was again impressed by the use of the guideliner to pass the OCT. It was the case this morning, and it was really well done. And it's true that in this particular challenging situation with the tortuosity on the proximal segment plus calcification, the user guideliner can give you the opportunity and can facilitate the crossing of the lesion by the OCT catheter. So this is very important. The rest concerning the debulking or not the lesion before stenting, it's true that when you see the result by OCT, we will be maybe easier and to move to the balloon followed by stenting. And it's true that without OCT, maybe we will be inclined to use a debulking device in order to facilitate. But it's true that what Mohammed Sobhi said, 25% ejection fraction for rotablator, that could be a problem. In case of any complication, remember that in the clinical presentation, the presentation of the patient, there is akinesia on the inferior wall. So if you have akinesia inferior wall, 25% ejection, and if you get no reflow phenomenon using rotablate in LAD, this could be really a major problem concerning hemodynamics.
Hussam, I see you have some trouble with getting the sheathless.
I'm going to bore you with this, yeah.
Is this a sheathless guide?
Yeah.
Why don't you-
We had difficulty with it earlier.
We changed actually to JR4 just to try to engage the ascending aorta.
Okay. So we'll leave you do that since I was suggesting to forget about the sheathless guide and use your regular guide to get the case going. But
Yeah, I just did that.
yeah.
But it's, we had difficulty in actually doing that earlier as well, it's just unfortunately. But anyway, that's live.
You can go femoral or the left radial. You can have your time. Well, we're not going to put any pressure on you, Hussam.
Just give me 2 minutes, yeah?
I know you're skilled enough to get out of this problem. Now, I think this is it's a great demonstration that imaging has helped us avoid rotablation, because this patient, otherwise, if we go directly with rotablation, it could be detrimental, especially that it's a LAD with everything else is diseased. And here was a kinetic circ is diseased. So doing that, actually, they proved the point where the balloon opened quite nicely. Dr. Alam?
Yeah, I wanted to comment on the use of FFR in the area of akinesis. I think you see significant drop in the diastolic pressure, but because you have akinesis, the flow is low. So I think FFR will give you a falsely low result. This is a big RCA. The region is quite suspicious. I think I will come back to it later probably, but it's not the culprit lesion. But I will not rely on FFR measurement in this case, or perhaps I will give a bigger dose of adenosine. But the resting flow and the hyperemia are limited in an area of akinesis, and therefore this lesion will not be well represented by a 0.8 FFR, because the flow already is decreased due to the scar. So in an area of a scar, we have to be careful how to interpret lesions to flow.
But also
maybe you can.
That RCA was supplying the LAD as well. You can see the collaterals from the right to the LAD. So if anything, it could have been, in a way, falsely positive.
Yeah, it's an important point. It has inferior akinesia. He had this lesion on the proximal LAD. There are some collateral flow from right to left. How do you interpret the FFR in this particular case? What are the risks to have a misinterpretation of the result, positive or negative?
No, it's a very good point. I think that it's very good to use physiology in a case like this, but you have to be cautious when you interpret it. To me, the main concern is the very depressed left ventricular ejection fraction. I can imagine that, the left ventricular diastolic pressure will be high, and that immediately will bring up the value of your FFR. This is something. So it's not only the collaterals, as Hassan has said rightly, and not only the ability perhaps to have vasodilation, but it's mainly the fact that you are using FFR in that situation where Nico Pales and Bernard de Bruyne said, okay, well, forget about venous pressure, forget about it, because it's normal. Let's imagine that it is normal. And the whole framework of FFR is in that particular type of patient. So we know that when you have high left ventricular diastolic pressure, high venous pressure, you have to be cautious. But on the other hand, I must say that the value that they found in the right coronary artery is close to the cutoff. It is not overtly normal. So, my impression is that they are doing the right thing. There is, in a patient like this, there is time later to discuss what to do. I will concentrate in what is really matters, which is the LAD, like they are doing. That's basically my comment. And what you can also see when you see people like Hassan and her colleague, Shihin, is that they do this routinely. And that's the reason because they are using a guide liner, because they are used that, that this is a very sort of simple step in cases where you have these difficulties in advancing the OCT. It's not something exceptional. You can see that they do this regularly and that they know that circumventing these small problems is going to bring them a lot of information. It was beautiful in the first case, and in this case, how they use the information to plan the procedure.
We notice, Hussam, that you changed to femoral, and you have the guide in.
Yes, because
For the sake of time.
Yeah.
What guide is
So I changed
this?
to femoral. This is EBU35.
Okay.
7 French.
Going with the stent now.
So I
The
think
3.0.
we will go ahead with the stent. We have a 3048. We're going to deploy that, and hopefully we can do an OCT after that. Hopefully now I don't have the guide extension, so let's see how it goes of this without the guide extension.
So that's why you don't want to wire the diagonal, I guess, Hussam.
Yeah.
Yes.
So I think I need the guide extension. Give me the guide extension, because this is not going to go. Because it's not going to go. It's not because of the calcium. It's the bend.
Yeah.
Okay. Give me the guide extension back and the 2.0 balloon.
I think obviously
Whatever
a problem that they faced is that there's a very acute angle with the supraortic trunk and the aorta.
Yeah.
And perhaps a good teaching point is for the colleagues is that if they're embarking in such a complex case like this and they know beforehand, because probably they didn't know, perhaps it would be better to go with a left radial approach. We typically do it, for example, for CTOs in the right coronary artery. We prefer to go for the right coronary catheter using the left radial approach. I don't know if you want to comment something about this, Jan.
Yeah, I think that this is an advice for all of you. And when we have this kind of difficult anatomy with the difficulty to get a good position with the guiding catheter, and particularly in a high-risk patient like that with 25% ejection fraction, if you have difficulty via right radial access, do not hesitate to move to the left or to the femoral. Personally, I move to the femoral because we cannot take the risk to have, a really difficult problem, movement of the stent before the stent implantation, etc. So it's really safer to change the access. It takes 5 minutes to do it, but safer for the patient. This is really a good example that it's better to move from radial to femoral in order to have a safer procedure.
Can you change the guiding in such cases into left amplas catheter? I know it's very crucial.
I think it's XP 3.5, but
I know, but the good angulation here. So he needs something to jump in the LAD. So maybe left ampla, the arch is big. So
the angulation is actually in the proximal LAD. That's giving the problem. It's not the ostial.
Or he used a parallel wire now.
Can I, Ibrahim, Jan, what is the downside of just simply because you are anticipating that the long stent with this acute bend will give you a little bit of a difficulty of doing just two stents, like go distal and then come proximal and overlap with shorter two stents? What's the downside of doing that?
Sorry, Brian, I'm sorry I have to interrupt. So I had to put the guide liner there with an ancient technique. So if you look at the lateral, I bypassed that angulation. If you can see the tip of the guide liner. So now I'm going to advance the 48 millimeter balloon, and you can hopefully, a stent. And there we go. So it goes nice and easy. So I'm going to pull back the guide extension.
Nice.
Excellent.
And let's see. Here you go. Test, please.
Come back.
Beautiful.
I think I'm going to come back just a little bit. Test here, Shirin. I think that's pretty good position. You agree?
Absolutely, Hussam. It's a great position and a great technique to get the guide liner in.
Yeah. So you go just nominal. So this is a. So I'm gonna. Where is Arif? Arif is there. So I'm gonna stay up for 48 seconds now.
Oh, too bad.
Because 48 millimeter stent.
EF is 25, Hussam.
Yeah. Well, we're monitoring the hemodynamics, you can see, and his blood pressure is in the 60s at this moment. So I may not stay 48, but the PA pressure is going up to 24. It was PA diastolic is 27. So I'm not going to sit that long. How many? So I'm going to download 30 seconds down. 30 seconds down. Just 1 sec.
I think Hussam did an excellent demonstration of how to actually get the guide liner in. I mean, he had a balloon there. The balloon is going to make the guide liner coaxial. And if you noticed his hands when he was doing this, he and Shireen, they introduced the guide liner at the time that they deflated the balloon so that it goes smoothly into the vessel. So that was an excellent demonstration, Hussam.
Yeah, thank you. So I also took this advantage. I'm going to put the guide liner inside the stent. So I would not damage it later on if I need to, because I need to post-dilate a little bit. So that's there. Give me a 3.0 non-compliant balloon.
I think that was important because you had an angulation in the LAD, and that was causing the problem. So the guide liner was essential to be beyond that angulation. That was an important.
Yeah. Let's do a cine. I'm just going to do a cine. So let's go cine, make sure the diagonal is okay. There you go.
Already looks very beautiful.
Yeah. So I'm going to use a 3.0 non-compliant, 3.0 what, Shireen?
25.
3.0 25 NC balloon. And then we are going to use a very short 4-0 just at the just proximal to the diagonal, which you can see there's a pinch in it. But I'm not keen, to be honest with you, to chase that, because I can see he's with the EF of 20%. I think the most important vessel at this moment is the LAD.
So while you get the balloon up there, let me ask Hazem. Hazem, the diagonal is something that you would chase in this case?
No.
You would leave it alone? It's a
But
small...
I need, from the start, we are working in a very critical patient with very low ejection fraction in acute coronary syndrome. And the optimization of the BCI is very important, but the safety of this patient is more important. So from the start, as we discussed before, we can fix the L6 lesion to give some flow to the circulation. We can put a femoral sheath from the start while I am doing the radial approach. We can think about the assistant device. Because I think after the OCT, the optimization is very important to see the calcium, to see the lesion. And he did a very good job to passing the catheter of the OCT with using the guideliner. But at the end, the safety for this critical patient is very important.
I will be interested to know if the OCT catheter will pass without a guideliner now to take.
Straight.
Probably would, because you have straightened the vessel with a stent.
I just want to comment on I think it's very important to monitor the right-sided hemodynamics. This is a lost art in cardiology these days, but this is a critical example of how important to monitor PA diastolic pressure and anticipate ischemia before it happens, and take precautions, give nitrates, etc. Otherwise, patients could go to lung edema before you feel it, and with this LV dysfunction. So I think it's a great idea to have PA monitoring.
So you got the guideliner within the stent?
In our practice, anybody with EF is a high risk. We tend to do the right heart study, and we have a low threshold to put an Impella. Yeah. But not because we used to overuse the Impella before, so I don't want to overuse the Impella. Yeah. So if I see hemodynamics like this, I can proceed. But if any chance that things are not going well, so we can immediately put an Impella. So we did the 3-0 non-compliant balloon high pressures. I'm just going to use a 4-0 to post dilate the proximal segment just before that diagonal, and then I'll promise I'll get you an OCT as soon as we can.
So even using the 4-0 balloon proximally is guided by the OCT image, as you remember. It was around 4-0 proximally and 3-0 distally, and it's a 3-5 balloon stent, as I remember, right? 3-5-48. 3-5. 48. Yeah, 3-0-48, and again the same problem is that's a 4-0 balloon.
Stent boost.
Yes, it is.
408.
Okay.
Assistant.
So they're just doing a proximal optimization now, right? Just before the diagonal? That's what they're doing.
They're not doing proximal. They're doing proximal post-dilatation. Where it's
exchangeable terms.
Yeah. No, because proximal optimization is a term used mainly for bifurcation. I don't think he's worried about the bifurcation anymore.
But it's he's putting it just before the diagonal, so that's my point.
That's good.
Yeah.
Maybe.
Going up?
Yeah.
Well,
But you can see the calcium on the stent booster. It's just outside.
Yeah.
But you can see the expansion of the 4-0 balloon. Here we go.
Very nice.
Down. OCT. So
down 12.
So I'm going to use, since I have the guide extensions, I'm going to use that anyway to deliver the OCT catheter, because I think still the bend is there. I can show you in the LAO view, we still have a bend, even though we stented it, and the calcium. Since I have it, I don't want to waste time or even contrast going back and forth. So let's take the OCT catheter, please.
I know this is possibly an overstretched use of imaging. I mean, this emphasizes, the same theme that we're trying to acknowledge in most of the presentations of Gulf PCR this year, precision PCI, no guessing, make sure you know your vessels very well. And this is an excellent demonstration that how Hussam really insisted in getting the OCT done. And I think it made a difference. We understood the case and we did balloon dilatation, and that proved that it opened without resistance.
Brahim, regarding optimization, and speaking about optimization regarding only the imaging or the physiology as well. I mean, do you advise to have FFR after or not using just FFR to diagnose? Because at the past, we use FFR to see that to have optimal, there is no ischemia. Because in these patients, we don't need any ischemia because they improve the ejection fraction. Still, the blood pressure is 64. In spite of the fact that you improved. So do you think that...
I think that's a PA pressure, isn't it?
PA pressure?
Yeah.
Sorry. I'm sorry.
I think if you have, Dr. Subhi, I think because of presence of OCT imaging, which such a high resolution image, I don't think in the LAD you would need the FFR. I don't know. What do you think,
I think
Khafir?
there is a new data on IFR showing that pullback IFR post-stenting has shown that 1 out of 3 or 1 out of 4 are still ischemic by the time you put your stent.
Yes, there's residual.
Yeah.
Just
No, this is alone.
Yes,
No,
last week in the
OCT
JAC,
setting.
there is a
I don't know
residual
about
ischemia.
OCT setting.
Residual ischemia following stent authorization. So you need to have another FFR to see that,
cranial, please.
to improve optimization apart from OCT as well.
Yeah, I think it's a hot topic, and we are going to hear more and more about this in the immediate future. As you mentioned, the DEFINE PCI study, which basically was a blind pullback after stenting performed in a large study, demonstrated that there was about 25-30% of vessels were left with an stenosis behind that the operator did not realize that it was hemodynamically significant. It is true also that it is a bit more difficult to interpret than the pre-PCI, so to speak, physiology, but I think that we are going to hear more and more about this.
But Khafir, back to you. I mean, in the presence of OCT, I mean, after doing an OCT, which shows a good stent sizing, no stent waste, would you still need that? I mean, that's as.
I mean, the findings of DEFINE PCI found that this residual stenosis that was significant occurred in 1/3 of the cases distal to the stent, 1/3 of the cases inside the stent, 1/3 of the cases proximal. But I think that you have to be sensible about that. In this patient, you don't see angiographically any distal stenosis, and I think that probably this is, as you say, OCT is what matters now to check what is the result of the intervention.
What about the IMR? I mean,
I'm just going to show you the
resistance.
The OCT that we just did. No, that's not. Okay, can you, is the OCT up there?
Yes, we can see that OCT.
Okay, so my other algorithm or acronym that I follow is ELA. E means the edges. Do we have a distal proximal edge dissection? A is the lumen and A is opposition. So I think the easiest is just, can you put in the opposition indicator, please? The software has the automatic. So if you look at the opposition, I mean, there's almost all white. The red areas where you have the branches probably. But we're going to look into that a little bit. Go to the red area, Mohammed. So that's all artifact there. It's okay?
Yes, artifact.
Okay, so then you basically double check on the red areas. And let's go on the more proximal one and also the artifact. So the stent is well opposed. Now we need to look at the MLA of, sorry, distal edge. Do we have a distal edge dissection?
No distal edge.
Can you go distal edge, Mohammed? So we don't have any distal edge dissection. And then let's run the MLA. Stop here. So you see the MLA is less than 4.5. You calibrated? Okay. So I'm not happy much with the MLA.
So that is the proximal part of the stent, isn't it? I mean, this is very proximal.
Yeah. So go back in the mid segment. Let's see.
Can we
Yeah,
check
here.
the
Let's see
MLA?
here. What's the MLA in here?
3.2. Oh, okay, here.
Yeah.
So med segment is 7.9.
Okay, let's go from the distal to proximal. Let's measure the MLAs. So from distal, so the distal is 5 point something, it's more than 4.5 in absolute numbers. And just walk it back to the prox. So still good, still good, still good. So the pose well expanded. MLA is more than 4.5 throughout the stented segment. And it's a tapered vessel. And then we go more. It's more 8, around 8 and 7 the proximal segment. So I'm very much pleased. But the only thing I don't have in this run is I don't have the proximal edge because the guideliner is just within the stent. It is a long segment. So I'm going to do one last shot in here, and then we should be done soon.
I think it's important because obviously it looks like it is at the place where you had that calcium nodule where you have some problems of expansion. It's the proximal part. But otherwise, it looks really, really good. So looks like the job that probably you have to do is just in that proximal part of the stent.
But that is the segment that you have inflated with a 4O balloon, right?
Yeah, but
Yes.
I haven't imaged that yet, Ibrahim. To be tester. Okay, I think I'm going to put the guideliner in there and be ready for the last OCT. Okay, ready?
Another run.
So I'm mainly concentrating on the more prox.
Can you do this?
Okay, let me just do it. Ready?
Go.
So Mohammed, just show us more the proximal.
segment.
So that's the proximal segment of the
Can we
stent.
check the MLA as well?
Can you look at the MLA? No, she doesn't. He doesn't know.
Maybe you need to go more distal,
2.9.
more distal.
Yeah, no, I need more proximal.
Sometimes
More
what is,
distal.
what is
Can you
good is
take care
to
of
have a look to the detection that the device is doing, have a look to the edges, because sometimes what happens is that it's not tracing rightly the edge. I think it should be properly edged, but I will personally look to how it is being, the contour of the lumen is being detected by the machine without trusting the measurements.
Go on more prox.
7.7 proximal.
Yeah, so this proximal 7.7. Just, I want to see if we have any proximal edge dissection, EJ.
Go proximal toward the left.
Yeah,
mid.
and that's the
Okay.
proximal. So we have some calcium there
But no
from the
dissection.
3 to 5 p.m., but there's no lesion, no dissection in anywhere. There's some in there.
What is that in
Just go back.
2 o'clock?
Go,
Or
go more proximal. Go more proximal. Go more. I'm not sure with this dissection or not, to be honest with you. Change the angle. Rotation. And this is it doesn't look like a dissection to me.
Here.
I think I'm not concerned about that, Ibrahim. I'm more concerned about the area about 35, if you see it on the longitudinal.
Exactly, yeah.
Can you go there on the,
yeah,
Go back to the 35,
that is the
Right there.
tightest segment of the stent.
Yeah. 35,
Yes.
What's the MLA there?
And in this area, is the image you see, it's due to the tortuosity of the vessel, which is a little bit,
Where's
you know,
the angle?
straight by the
Go back
the
at that. No,
catheter.
here. Yeah. And now rotate a little bit. So the MLA is 5.6.
6.
And as Dr. Fajr, they said, it's basically due to angulation.
Hassan, why don't you show the borders? Ask the technician to show the borders that is being identified. I think that is important because perhaps the machine
Pardon
is...
me?
What do you mean by border?
Well,
position, you mean?
you can see the detection that the machine is doing of the luminal edges.
Show the border of the machine
Show the
detection
borders. So
of the border.
If you go to the icon with the eye, or with the ruler on the top, icon to the ruler, left upper corner, and then you click there, and then you just check that you can see it.
That's too little.
You guys are doing it or no?
They don't hear.
No, no.
We
Left
need-
upper corner.
We need to see the
Yeah.
dots.
Okay, go
the
to
dots.
the left upper corner, to the
Ruler.
top.
You're not
Left.
talking about the opposition indicator, right?
Yeah. No, I'm talking left up more. This is not the upper one.
Ruler, the ruler on the
Left-
top.
Left upper.
The ruler.
The
on
ruler,
top.
left upper.
That's not the ruler.
Higher,
the ruler is
higher.
on the top.
Yeah.
Okay.
Left, we're under the cases.
You
Let me
can see
just
where
do
the
it.
case is. There's a ruler over there.
Yeah, yeah. Excuse me, I'm going to do it.
It's,
All right.
it's a tortuosity, I think.
Go to
Okay,
the ruler
Amira,
on the
you're
top.
gonna walk me
yeah.
through this,
Okay,
yeah?
and now say lumen contour. Click
Lumen
in
contour.
lumen contour. And
Yeah,
this is
here you go.
important because it's, for example, in this place, the contour is actually fooling you. It's not really showing you you notice that. So you have to really check
Yes.
that the machine is really tracking. Did you see that? I mean, the point where it's telling you that it's 3 millimeters squares is actually more than that. So you have to have a look to that.
Correct.
Right.
There, for
You
example,
see, there was, the contour was wrong.
the contour
Yeah.
was wrong. So it's important
right.
to double check. Don't trust
Fantastic.
the system you see by default.
No,
Gotcha.
go back,
So we're-
Hussam. Go back to the where it is the 35. Go to 35. Stop. Go back.
Go to
No.
35,
Shh.
DJ. Stop.
Okay. This is the point that Khafir is making. We need maybe go back to where the indication of the machine is wrong.
Yeah.
So to the red marker.
Yes.
So this is where it says 3.0 because this is for 4.3.
No. Go proximal.
More
Proximal.
proximal.
Go more proximal.
About you already passed it.
You passed
You
it.
passed it. It is a
already.
small segment that you missed it.
Yeah. Right there.
More distal now. More distal. More distal.
More distal. One
More. Yes.
That's the
Here.
point. So here, if you go again to the ruler, to the top, go to the ruler at the top, okay, and lock it. You see that that lock that you have over there? Click on the lock.
Yeah.
Click on the lock, okay, and now you can trace it.
Yeah.
You can manually go and trace it. Just move the green. Well, just to show that the machine is actually gives you a lot of flexibility. I mean, you can really enhance.
Yeah.
Okay. So you see, you have improved by the luminal area now to more than 4 millimeters.
Accept.
Yeah.
Four now.
Yeah.
So we're running very short on time. I think it was a great demonstration. So what are you going to do? We need to see the last angio, Hussam, before we can lose you.
I think, yeah, I'm just going to do a final angio and then we'll stop after that. I think we're all good. I'm happy with
Take
that.
the OCT off.
You will fix the
Maybe
LCX
you
in
can do-
this session or not, Ibrahim? You will fix the LCX or not?
They will do it later.
We'll do it later.
Not in this session.
It looks
That's
beautiful.
the final angio.
Great job, Hussam. That was a great job. Are you gonna? Hussam and Shireen.
You see the angle on the lateral view, it's a heavily angulated lesion, but I think we're very pleased with the result. I think we will join you shortly in the React PCR. Thank you very much and for guiding us through this fantastic case.
Thank you.
Thank you, Hussam.
Thank you.